We're lucky enough that we have Skip Rizzo here from USC, and truthfully, it turns out 16 years ago, we started bringing him in because he was doing such fabulous stuff then. And nobody in our group has yet gone into virtual reality, which is what Skip's been working on and been a leader on for the last 20 years. And so in a minute, I'm going to introduce him because, but first, we have really good internal news. And maybe not everybody knows that Sean became a father 2 days ago.
Thank you.
And his daughter Melody Isabel, 2 days old.
We want pictures.
We'll send some. Yeah,
You should be here.
about 5
You
minutes.
should. I'll say that. And I know that we have somebody here that I don't know, so I'm going to ask you at least to introduce yourself.
Richard.
Oh, you're with Skip.
Yep,
Okay.
yep.
Yeah, I'm with Skip, so I'm a visiting cinematographer from Australia. I'm just connected with Skip today. And virtual reality is in the infancy stages in Australia. There's obviously more being done here. Skip's obviously one of the authorities that I've followed on the internet, and Skip's kindly invited me along to the lecture, so thank you for your time too.
So I wouldn't have to say it twice.
Exactly. Didn't become the flight translator.
So Skip was working in the area of virtual reality when it was just new, and I did get to visit his laboratory like 15 years ago, and at that time it was unbelievable. Now, of course, he says there's been $70 million worth of investment, so they've made quite a few advancements. And he was working with ADHD kids, and we actually in the Commons down on 3rd Street, we bought one of these like headsets, and kids with ADHD, you could watch how distractible they were and how you could train them to stay on task. He had really fabulous, interesting virtual reality programs. But today he does organize a global network of people that have been working, and for a number of years I monitored it, but I could never make it to the meetings, which are always held in fabulous places for the young men and women who are working in tech. And he's done a lot of work on trauma and a lot of work for the military. And while it might not be specific to HIV, all the issues he's bringing up are certainly issues that are relevant to our daily work and the kinds of technology, whether it's in social media, in self-monitoring, or in behavioral interventions. And we only apologize because we have a number of guys at Medicine 2.0. It happens to be in Maui this year.
So everybody wanted to go.
Dallas is not here. A number of people are not coming back from this meeting that ended last week until later this week. And a number of maybe are coming back this week. And we have a large group who works in Asia, and they're all in Asia. So we apologize for a smaller group today, but believe me, we're hoping that we can keep your slides, and
Yep.
everybody's been looking forward to this.
Absolutely.
Thanks for
Okay, well, thank you. That's a nice introduction. Okay, I want to talk about the work we've done over the last few years that's been primarily military funded, but I think at the end you'll get to see how everything we've done for them is going to end up having some civilian payoff, and is already in some cases. What I'll try to cover is talk about our work with exposure therapy for PTS, a little bit on resilience training, try to put ourselves out of a job on the back end by doing a better job on the front end using VR. A really cool project for training novice clinicians with virtual humans, and an online intelligent agent architecture that we've built so that people can interact with a virtual human online and get healthcare information. You'll see all of that as we move along. This is where we are. Fortunately, I'm not downtown at the main campus. We have our own place out in Playa Vista, our own building. We're an Army UARC, so we're a university-affiliated research center. So we do get significant funding through the Army. And they selected USC because of its proximity to Hollywood. They wanted the Hollywood Brain Trust involved in building simulations and multimedia and adding narrative to simulations, things like that. So we're like the unholy alliance between Hollywood, the military, and academia. Three completely different cultures, but we get along somehow, and come up with some neat stuff. And my team's the Med VR lab, and an interdisciplinary team of folks, docs, OTs, PTs, computer scientists, artists. These are the leaders, but there's a whole subset underneath. And over the years, we've evolved projects in psych, cognitive, motor, and our virtual human work. And just quick video, see how the sound works here. Do you have sound?
Yeah.
Because there should be some, maybe I don't have sound on. Let me make sure. No, mine's on. We will need sound.
Is Pete Kushbe with
Yeah.
Pete
Pete.
and Stefan?
Stefan, sure.
Yeah.
You're going to see some of the work that we do together with the Sim Sensei project.
Okay, great.
Yeah. How do you know those guys?
Pete, I used to work at NASA, and I knew Pete from back up there on virtual environment stuff.
Yeah. Peter's a good guy. Smart guy, too. I have a little mini speaker that I can plug in if you have a splitter.
Is that?
Oh. Yeah, that's the soft sound. I don't have it blaring. But this is an idea as to what a VR simulation looks like. And this is one that you'll see a bit more, so I'm not going to talk too much on it. But over here is what that world looked like about 5 years ago, so you can see the graphic difference. And what we did was basically take the world we had developed for exposure therapy and thought, why not develop tests of attention, memory, executive function, where you have to navigate in the world and remember things, or you have to attend to things over time. And a whole set of projects came out of that. But we also do the civilian work, and Peter is involved in some weighing in on some of this mental rotation work. But this was an old 3D projection system for testing and training mental rotation or spatial abilities. And then the virtual classroom, this is what that looked like, and this is what a child sees wearing a VR headset as they look around. The thing with a headset is that there's a tracker that tells the computer in real time where you're looking, and the graphics update, so you get the illusion of being in the environment. And so the child would have to pay attention to stuff on the board or from the teacher, but meanwhile, you saw a paper airplane the kid just threw and a bus going by. And so we had this controlled stimulus environment where we could test how well children could pay attention while we systematically made people pass notes, or this little kid's going to drop a book on the floor and make a big noise. There we go. So,
I just want to comment, like, I've been in this laboratory, so imagine that VR thing, but it's this whole room with 3 walls, and the noises are like real battle and things like that.
This is our work in rehab, motor, specifically sensory motor rehab, following stroke or TBI, or any. We actually ran a group of children partnering here. And I'm blanking on her name, but with children with cerebral palsy, basically trying to use the Microsoft Kinect camera to make games more accessible for those kids. But in this case, basically, that user is not wearing any equipment. It's just being tracked by a 3D camera, and her actions are being replicated there. A little bit of a range of motion. All this is off the shelf. That's a standard TV, $150 Kinect, regular computer. So you could see this stuff ending up in people's homes so that they can do rehab at home, do it at the level they need to do it. Next one is the virtual patient project. I'll show an older version of a patient here. This is something we did with the School of Social Work to train novice clinicians interaction with a virtual patient. They have a master's in military social work program, and I hope the sound comes through on this. I don't know if you can hear that very well. Can we get a little more volume? Do you need the volume on this for that recording? Because I have a little speaker that. This is one of these little speakers, but they crank out stuff pretty powerfully. basically, what's going on there is this clinician asked some questions about why you're coming in, and he mentioned, well, my wife wanted me to come in and talk to someone because since there was a suicide on base, so then the clinician can then go into a suicide assessment. All right, here we go. Let's go back to this.
Did you see her? What brings you in today?
Well, my wife told me she thought I should talk to someone. She's been pretty concerned about me since they said suicide on business.
Did you happen to know the soldier?
There we go.
Yes. He was a friend.
So you get the idea.
Twice.
Novice clinicians can mess up a bunch with a digital case before they get their hands on a live one. And next is a online agent called SimCoach, which we'll see more of later, but I'll let him introduce himself now.
Well, I'm not a real person, if that's what you're asking. But I'm based on the personality and experiences of real soldiers and Marines. I'm still just a piece of software, but I'm getting better all the time. So hopefully I can be a helpful piece of software to talk to.
Sort of like an old Anderson Cooper.
Was on the former screen where they were
Yeah.
doing the consult with the virtual patient, the one where there was the suicide on base, is somebody live doing the responses to that? Or
No, that's all software. It's all software with a dialogue management system, and in that case, pretty decent voice recognition. So I think there was the Google. We've experimented with all the different voice things. I think it was Google, and that was pretty good. It was like 95% hit. But with any of the language interaction, that's something you have to really think hard and basically put something out and test with users and evolve it, because you don't need to have the patient be able to answer who's going to win the World Series or who won the World Series in '65, but you want to be able to have all the domain relevant questions. So you got to plan for that. Okay, so VR real quick, technocentric definition, combination of technologies, computers, interface technology, body tracking, sensory displays. Probably the easier one and better one is the human-centric definition, more around making it so people can interact with computers and complex data more natural and intuitively. So if we see how people have been interacting with computers for the last 20 years, maybe we can do things with VR so you're not just hunting and pecking on a keyboard. There's so much power in these things now, we can start to do more with them. Best metaphor in mental health and rehab, aviation simulation. Just as an aircraft simulator, test and train piloting abilities. We can test, train, teach, treat, range of functions in a controlled stimulus environment safely in ways that are very difficult to do otherwise. The real world is a great training environment, but can you control it? Do you have enough human resources to manage everything? In '94, simple phobias were the area that VR first got some clinical traction, because it wasn't a big interface demand. All you had to do was build a world that you can make more and more provocative, that addressed fear of heights, fear of flying, and patients just had to show up. And good data started to come out of it. Since then, short list of the different clinical conditions, and there are more, that VR has been usefully applied: assessment, research, or intervention. So let's talk about VR exposure therapy. So in the beginning, there was exposure therapy. Like I said, it was the first area, and exposure is this process of gradually exposing people to things that they fear or that make them anxious or that they avoid, help them to confront their fears, or in PTS, confront and process difficult emotional memories, and eventually you see extinction learning, but I think there's also a processing component that leads to good clinical outcomes. These are the various simple, specific anxiety conditions. So here's 97, if you were in Spain, you had claustrophobia, they'd close the door on you and you were in this room, and then they'd bring the wall in eventually. But you can see now the graphics have gotten better, a little bit more realistic, even though they don't have to be an exact replica for the brain to kind of react to them as if they're real. And we do see good clinical outcomes. We did a meta-analysis in 2008, same time another group did, and found VR to be more effective than pure imaginal exposure alone, and as good as in vivo when there was an in vivo condition in the studies. And another meta-analysis came out following up in 2012, same data, or same results. So the application for PTSD. Well, we know we've got a significant healthcare challenge on our hands from these wars in Iraq and Afghanistan. This is from VA data, 31% of admissions that year for mental health diagnoses. Everybody here knows PTSD, right? I'm not going to spend, I don't want to waste too much time on this. The symptoms, the trauma, this is DSM-5, you've got the 4 symptom categories now. And in an early IOM report, basically it was found that that not a lot of treatments really worked so well for PTSD, but one that there was enough empirical evidence to say that it was evidence-based was prolonged exposure. A lot of times when people aren't behaviorally oriented or they don't know about the research, a lot of times their first response is, why would you do that? Why would you make somebody that's been traumatized go back and relive it? Well, we do that because the data tell us that it works. And supportive counseling, as great as that is and a good thing to have along the way, on its own does not lead to any positive outcomes. You've got to address the trauma and prevent avoidance and support processing. And you can do it graduated. So they endorsed it in 2008 in the standard format. And our pitch has always been engagement in the trauma memories is related to clinical outcomes. Low engagement, poor outcomes. If we can help patients to confront and process more effectively and do it systematically, then maybe we can do a better job of it. Joanne DeFede is my colleague who has done the World Trade Center VR environments and published. You'll see some of her data later. And in the 2012 and 14 IOM reports, one of the recommendations was that we need to continue to pursue the use of technology, not to replace humans, but to fill the giant, massive gaps in healthcare, in the DoD and the VA, because there aren't enough humans in the loop to deliver proper care. And there's a lot of barriers to care. And I'll talk about that as it relates to this. So 2003, we had the idea, take an existing game that the military had actually funded as a training tool, but was now being released on the Xbox, and USC had a hand in some of the development. And we didn't have any funding, so we just yanked the street out of the game and modified it a little bit as a prototype to shop around and say, hey, in case it's needed, because it was still 2003, people didn't know the extent of the problem, in case it's needed, let's be ready. And we actually got shut down in 2 funding sources saying it's probably not going to be needed. I think they believed the mission accomplished sign on that aircraft carrier. But this is what it looked like, and without any sound, this is user navigating. Then you could hit a button on the computer and get some ambient sound, hit another button, and all of a sudden you'd hear gunfire.
So this is like America's Army, but applied.
Yeah, and this was a follow-up to it. It was like America's Army was about recruitment. This was about training and squad tactics. Add in the sound of the helicopter there. I missed my cue. But it was all on one computer with a headset, VR headset, and you'd hit buttons. Well, we sent it to Iraq. This was one of my former grad students, Greg Rieger. He was in the military. He went to Iraq, and he took a system with it. So this is a guy in Iraq, in virtual Iraq. And it wasn't for treatment. It was just to get information, user-centered feedback, boots on the ground telling us what we got right, what we got wrong. what we needed to evolve. And Greg continued this work up at Fort Lewis and kept getting us more information. And that was essential in the building of the first system, actually the second system that was funded. The first one was the prototype. So we were funded by the Office of Naval Research back in 2005, and these were sort of the requirements that we proposed, that we'd have a variety of scenarios, different ways the user could go through it, a library of trigger stimuli that a clinician could deliver properly at the right time and place, and try to help support the evocation, if you will, of the trauma memory. And we wanted to go multi-sensory, smell machine, vibrating platform that the users chair or that they would stand on. So the sound would run through it, and these subwoofers would enhance the sound, so if you could feel the motor of the Humvee, or a bomb goes off farther away, a little bit of a bump, but as it was closer, you'd feel it. And that was a big thing. And we used some props, monitor physiology along the way. But the goal was we couldn't build 100 different scenarios, but we built 4. We had enough money to build 4 that we could modify in different ways to make them customizable. So this is what that looked like. Here's a montage of toe in the water, safe desert environment, 24-block city that was mixed Middle East, and then an Afghan and an Iraq driving scenario in a Humvee. And the clinician could blow things up, could change the time of day, the weather conditions, lighting. You get to the bridge, if they hit a button, an insurgent attack from a bridge would occur, IEDs, and so on. Now, in 2011, we were funded to rebuild everything based on what we had learned in the second prototype, from stories that patients would be telling us, because they don't just put on the headset and the graphics take off and they're fixed. They're basically wearing a headset and they're narrating their story. They're talking about the trauma, and the clinician is setting it up so that what their story is being somewhat resembled. So driving in a Humvee or driving in an MRAP, click a button, it's an MRAP now. It was a cloudy day, clouds in the sky. There wasn't any sound, just the sound of the motor, just the sound of the motor. Then I heard a wind hit the thing, there was wind, and I didn't feel right. It was a cold wind or whatever. And then we hit an IED, and my best friend died. And that would be a very initial cognitive sanitized story that you typically hear, just the facts. What the clinician's goal is to help the patient pull up the emotions that go along with it. And so that's therapeutic exposure. Let's take it back a few steps. What were you doing before you got in the Humvee? Tell me about your friend, and so on. And so that's how the course of this stuff goes. But, yeah.
How you said you were evaluating everyone. I'm curious what kinds of evaluations you were doing that led to your redesign.
Yeah. I'll show data. I'll show some of the outcome data based on the standard metrics of self-report and clinician-administered PTSD skills, stuff like that. But as far as the rebuild, because they're narrating their story, we heard from all the clinicians about everything that they couldn't do in the environment that was coming out in the stories. We only had 4 worlds. And what about a guy that was in an Afghan village and saw a dead child? And that haunted him when he came back and saw his own kid. We didn't have an Afghan village. So we'd have to have somebody get out in mountainous terrain and walk around. And then, without turning off their imagination, or using their imagination still. So it was a mix of the VR, when it matched the scenarios that the person had experienced, that was good. When it didn't, clinicians would have to go as close as they could and then say, okay, now imagine that. And the good news is that folks with PTSD, it doesn't take a lot to activate them. And with this stuff, we could all put on the headset and say, it looks like a bad video game. But if you've been over there, and if you've had something provocative happen, all of a sudden, you know, and then smell machine, the smell of Iraqi spice or rotting garbage or diesel fuel, burning rubber. All of a sudden, now it becomes easier. So all those stories we heard about and documented, this thing went out to 60 different places. So we got a lot of feedback from clinicians that wanted to see the thing grow. And so you'll see that in the next slide here. 14 scenarios, library of about 300 sounds, features that we could only dream of before, expansive environments, and I'll let this patient do some talking here.
By going through it there, it's not going through my head at night when I'm trying to sleep or when I'm with my wife, and times when I don't want it to come up and me start thinking about it. Traumatic things are not normal. You cannot handle the things that we've seen and done. And this is a tool that has helped me out tremendously.
Reliving the worst moments of his life has helped him to move on with his life.
I'm probably about 80% of who I was before I left. But I think that's good after seeing them doing the things that we've done.
For Nightline, this is Dan Harris in Atlanta.
So, 14 worlds, a library of sound effects that you can customize to the patient and have a store profile, standardized settings, because every environment you want to be able to control time of day, ambient sound, weather, sandstorm, fog, whatever, and then specific events due to the nature, like a vehicle-borne IED is common in these. IEDs, you can set IEDs off anywhere, any distance, any orientation. You can go in a helicopter and fly over a space, and so on. Yeah.
Are the patients just brought in immediately to reenact the scenario, or does it take time?
3 sessions at the start are standard, get to know the patient, psychoeducation, some breathing, and then a little bit of imaginal warm-up, and then usually session 4, the start of it is going through the American desert. It's like driving through Mojave, but you're in a Humvee or an MRAP. But it's very much like driving out east
But
here.
not with explosions?
Nothing. And then during those sessions, that's where the real therapy comes in. With the clinician getting to know the patient, know what their traumas were, and then conceptualizing a hierarchy and which one are we going to tackle first, and what are we going to do for homework in between the sessions, and so on.
And you're measuring arousal and things during
Well, we're recording heart rate, skin conductance, and respiration, but that is more like another measure, like a SUDS rating from the patient, the subjective units of discomfort rating. Sometimes somebody might say, "Oh no, out of 100, my SUDS are 20," but their heart rate is going fast. So you want to have the physiology when you can. I want to underscore that the technology doesn't fix anybody. This is simply a tool to extend the skills of a good clinician. And so in the second version, this is what the interface looked like, hit buttons. You could see what the user was seeing there. That was a tablet version. This is sort of the interface now with a separate screen, so the clinician actually sees what the user is seeing as they turn their head, and has this control panel here. You can set the distance of an IED and set it off in any orientation. This is for one of the road things. You can see ambience here, wind, fog, dirt road, roadside debris, yes, no, distant effect. Well, where was the user? Are they driving? Are they in the front or the passenger seats or up in the turret? So we can customize things. You throw in an MRAP.
So this could be MSM and gay sex. Imagine
Maybe all
what the
sorts of
triggers
things.
might be. Yeah.
Wherever you decide to model. So some of the data. Of course, you always publish your first best case study, and so that was one in just 4 sessions. Barbara Rothbaum's group at Emory University, and then Greg Rieger published his up at Fort Lewis, first case, and then we were funded by the Navy, Office of Naval Research, to do a feasibility trial. And it ended up that we got 20 people, 20 treatment completers. But as I said, the first 3 sessions, kind of a warm-up, and 4 through 10 is where you really start to bring on the VR. So in this sample of completers, only 1 female, average age 28, 8 years in the military, multiple deployments. And because this was still 2007 or so, this was still considered to be Star Trek. And even though we held tight that we're delivering the exact same protocol as Edna Foa had designed for prolonged exposure, we're just adding in the VR, it was still considered to be sci-fi, so we could only get patients who had gone through some evidence-based treatment with no benefit. So here's the data from that. No control group, this open clinical trial. Pre on the PCLM, the standard military screening, self-report. Post and 3-month follow-up. These are the 16 that no longer met PTSD criteria at the end of treatment. This is a big issue in the military. Do you call it PTS or PTSD? You know, I've kind of made myself get in the habit of saying we're treating post-traumatic stress, leave off the disorder, but you got to have the, you know, in clinical circles, that's what we deal with. We try to destigmatize what people go through as much as we can. Anyway, 16, 4 did not benefit. The Beck anxiety and the PHQ, the patient health questionnaire depression scale, same pattern of results. Let's see. And then Greg Rieger did his own open clinical trial and found similar results up at Fort Lewis with a more difficult population, I think. These were really ground pounders that he was working with, so we're pretty happy to get even that 15-point reduction, but it's a good effect size. Well, I'll talk more about the randomized control trials that are ongoing in a second, but yeah.
Were you able to determine any engagement level or the types of stressors for the 4 who didn't benefit at all relative to the 16?
You know, I didn't run this study. It was, you know, I was hands off. It was run down at San Diego Naval Medical Center and at Camp Pendleton. And so I would occasionally review videotapes for protocol fidelity. But the cases that didn't benefit, I don't know whether to trust what I was hearing, but in some cases, this is somebody who wants disability. This is somebody who wants out of the military. This is somebody that their sergeant is making them come to therapy. But, you know, it's just too small a sample to say. And I'll be honest, you know, so far we've just thrown everything into, you know, all the stimuli. These are the kinds of studies that we really need to do. We recorded physiology, but there was a problem with the heart rate and the skin conductance. We thought we could go back and look at physiology, maybe get a window into why these 4 didn't benefit, but the data was unusable. But that's changing now. And I think there's a lot of dissertations to be done. Like we use smell because, of course, olfactory bulb, limbic system, memory, emotion. Well, we don't have any data that it adds anything to the clinical outcomes. So, you know, and that's a costly piece of equipment. That's the most expensive piece of equipment of the whole thing. The headset, $1,000 and coming down, computer, a couple thousand, bass shaker, $400, and build it in your garage. Smell machine at the time, there were like 3,000, and the replacement smells were $100 a smell. So it's costly, but we just wanted to put the whole package together and then dismantle it later and see. And we've got a system at West Point, and some of the cadets want to start doing things there with it in their sim center. So, you know, maybe not with patients, but we can maybe measure activation with other service members. There's a lot of work still to be done. We've spent the last 110 years, psychology as a science of behavior in the real world. Now we got to start looking at behavior in the virtual world and find out what works and doesn't. But, you know, whether we beat Edna Foa's pure, prolonged imaginal exposure or not, doesn't matter, because as long as we're as good as it. Because there's other issues here, and I don't think there should be a one-size-fits-all when we've got these kinds of stats for people coming and getting help. Perhaps we can draw people into treatment that grew up digital. We seduce them with the idea of virtual reality therapy. Oh, yeah, I'll play video games and get better. They don't realize it's still hard medicine for a hard problem. And they're going to be activated, and they're going to be pushed, and they're going to be prevented from avoiding as much as is ethically sound for the treatment, because you want to prevent avoidance. So I look at it as as long as we're not hurting people and we're doing as good as the evidence-based care, then this is another option that may appeal to some folks. So these are the sites that had the second version, and these are the sites now that have the new version. There's a couple more. West Point is up there. A couple more that will be added to this now. It's gradually coming along, and we just released it at the end of the summer. So once you build these things, these environments, maybe there's other things you can do with them. So let me walk through some of these real fast. First off, there's 4 randomized control trials that are ongoing, looking at VR versus imaginal alone, VR plus trauma management therapy out of Florida, which is a psychosocial add-on, which I think is actually quite smart. Even though some people say, you just do prolonged exposure, that's all you need. Adding in this and that doesn't improve things. I don't know if I buy that. Anyway, so bunch of things, but one of the studies that are ongoing is with D-cycloserine, and that'll come up in a minute. I'll talk about that. Just real quick, we built, as I mentioned earlier, I don't want to spend a lot of time on it, we built a bunch of cognitive tests in the old version. Different things. You follow this guy around and you've had to memorize a list of 16 items for a recon, and you go to different stations.
Iraqi police.
All right, so now you're at this station and you got 1 minute to scan the environment. There's distractor objects and so on. And 2 of the, or 4 of the 16 are in this location. And monitoring, a very boring monitoring task. And one of our students started looking at physiological reactivity and cognitive performance under provocative conditions. The D-cycloserine work, if you're familiar with this is a old antibiotic medication developed for tuberculosis, has a direct effect on the amygdala. In lab animals, it shows, it's been shown to speed up extinction learning. So instead of 20 trials for the rat to stop cringing at the light, maybe it's 10 or 15 trials. And so this is data from a VR study for fear of heights, the D-cycloserine group, showing better outcomes over time. This is Joanne DeFede's recent data from 2013 in neuropsychopharmacology. And basically, I think it comes out to around session 6, they get the people that took the D-cycloserine during the exposure had outcomes that were similar to the placebo group at session 10, and then it kept going. Now, in imaginal exposure, there's been one negative outcome with it, but you have to look very closely at the dose level and the time in which it was administered before the treatment. And apparently, more is not better. It has an opposite reaction if you up it to, I forget what the dose levels were in that one study. But anyway, so that was her stuff with World Trade Center victims. We're doing the same study now, VR versus imaginal, D-cycloserine, placebo, looking at genetic markers, and doing that at the Long Beach VA, Cornell Medical College in New York, and at Walter Reed. So multi-site trial looking at that. At Walter Reed, Mike Roy looked at pre-post fMRIs, people going through the treatment, and showing changes in activation when presented in the magnet with provocative war stimuli, changes in the directions you would predict and hope. Very small study, I think 8 patients. Another three groups are actually looking at putting people in the simulation when they come back and measuring physiological reactivity, and also looking at their ability, their startle response, conditioning, and extinction. A puff of air to the neck, which doesn't hurt, but it causes a startle reaction. Measuring that to see when they're in the simulation, if there's a predictor that might predict who's susceptible or who's likely to develop PTSD. The Infinite Hero Foundation at Oakley Sunglasses funded our expansion for combat medics. We didn't really have a lot of blood and guts in our stuff. Exposure therapists sort of frown on it. They don't want to habituate people to things they should naturally be disturbed by. But with medics, that's part of the simulation, and it required a whole set of new content, so they funded that. And I'm going to let this one play out and get a drink. You can hear how like the sound is really kind of evocative. You know, this visual sort of set a place, but it's that sound that can be activating. I didn't have time to update this slide. I'll be frank, I'm looking for money to build this out for a couple of reasons. Number one, 98, Barbara Rothbaum built a virtual Vietnam scenario, very primitive, but it showed good clinical results in open clinical trials. But there wasn't any money to follow up and grow it because they're Vietnam vets. And number two, there's in our most recent Institute of Medicine report, 2013, 128,000 new cases at the VA, total VA system for PTSD, of which 62,000 are Vietnam era vets. So these guys are retiring, they got time on their hands, maybe they can't keep as active, so there's a need and there should be a commitment, you know, and we know that the data shows you can implement prolonged exposure 20, 30, 40 years later and still achieve some outcomes, some positive outcomes. So they deserve it. And so that's sort of a little mini crusade. I'm going to speak at the LA Athletic Club on Wednesday, and those guys got bucks. So I'm going to put in the the stats there, and really try to look for private foundation funding. I mean, it's not going to take much. We built a prototype. We just need to evolve it. But we have to pay for everything. Anyway. And now, the one that makes people get a little bit edgy, and we're funded to do this. Now, Barbara Rothbaum will be running this trial starting in January. Military sexual trauma is a big issue. When we went into thinking about it, I thought, well, we could convert what we have already. And then as I actually read more, I found out later on that most military sexual trauma doesn't happen in the foxholes of Iraq and Afghanistan. It's happening on bases here, so we have to build all this new content out. We're building a little town, and we're building barracks and so on. We're not simulating sexual assaults. We're simulating the context, the scenes, characters that can follow you around. We can reuse some of our stuff. So this is a mountain outpost, and it could also be up at 29 Palms as well. And we're really leveraging more cinematic approaches for lighting and sound effects and shadows. We can't make the characters look, we can't replicate the perpetrator for every person, so we're going to make them kind of vague. We do have them and try to use lighting to kind of shield their face a little bit. So this is where we're at with this. But it's more Hitchcock than Hurt Locker. It's more about building a context where somebody feels that hesitation that they're somewhere and something bad is happening and we're losing control and so on. Because what we're trying to do is to foster that confrontation, yeah.
What's your thoughts on habituation? So, based on age, younger people right now, the video games are so real that will it have the same effect on improving their symptoms because they're already more used to it?
I look at it not that we're using video game technology, and it looks a little bit like a video game, but we're creating an experience. And the game experience, fundamentally different than the experience that somebody with PTSD has when they're in these things and they don't get the fire back. There isn't the game, elements of, you get to waste as many bad guys. Sometimes you're getting shot at and the guy in the Humvee next to you has blood on him or, is moaning. So it's a good question, and actually submitted a proposal to NIH in 2006 to look at video game consumption in people when they came back and to see if there was maybe people were like trying to self-medicate or whatever, but we didn't get funded on that. But you bring up a good question. I mean, you look at, there's no doubt that 4-year-olds that are swiping, touch screens on iPads, they're going to be different, when they're 20 than I was, certainly, when I had 3 TV channels, with a knob and a rabbit ear antenna, That was my TV experience growing up. I'm an old guy. Yeah, this stuff we should study.
So, kind of working on that, something that seems distinct about the gaming situation or environment is the control. And are you trying to trigger the ability for them to reclaim control because they felt out of control and that was part of the trauma, or do you want to put them in a setting where there is no control and then have
So
them
I don't think
process
it.
that space?
I don't think it is. It's a case of like we're going to put you in the environment where you get to beat up your perpetrator this time and run them off. It's more about just being able to confront what happened and process it and talk about it. I'm out of my league, I'll be honest. I have ideas for clinical apps and I can build them, and sometimes in an area I know a lot about. I really rely a bunch on Barbara Rothbaum because before she got mixed up with this stuff in the war, that was what her work was sexual trauma victims with imaginal exposure. So I honestly I don't want to mangle the question too much, but she comes out regular. Go and have a beer and chat. Okay, now that clock isn't right. That's still on daylight savings time, right?
It's not 4 yet.
Okay, good. It says 2 minutes to 5. I was thinking I didn't talk for 2 hours. Okay, I'll try to wrap up, get through this, because I think this is important, not just for building skills, emotional coping skills beforehand for service members, but you can take this methodology in other areas, and then we'll get into the virtual human stuff. So we're into the part about prevention. And this is a project called STRIVE, Stress Resilience in Virtual Environments. And if you look at the military's perspective across the course of the war, this was an American psychologist, written by General Casey, with the battle cry here, psych fitness, recognized every bit as important as physical fitness, and we should go beyond treatment-centric to prevention and enhancement of psychological strength. The idea being with comprehensive soldier fitness and other resilience training systems is before you go to war. Let's take that 19-year-old who their only experience with stress was when, Mary Sue broke up with them before the junior prom, Now they're going to see their buddies die, or they're going to see dead children, or let's try to teach them cognitive behavioral coping skills. But they do it, this program, $125 million, Seligman, drove it, a lot of controversy about what came out of it. I believe in cognitive behavioral preparation, but they delivered it in a death by PowerPoint fashion. And they delivered it to trainers who, with no control, the trainers were the ones that were going to disseminate it to all the bases. Who knows how that ever went? They never really dug into it. But this is the part that's important, the recognition. So we decided with what we had already built, we could put ourselves out of a job in the back end, do a better job on the front end by taking that content and building an emotional obstacle course in which you could train coping skills. So the idea was put somebody in a VR environment, look at our worlds as the back lot at Universal Studios, and put people in a narrative where they're with a squad and they go, each episode, they go through a mission and they get to know the people in the squad. And at the end of each episode, something bad happens. And the bad thing that happens is modeled after what people often report as their trauma experiences. And we don't stop there, but let's just show you what a couple of those things look like. There'll be two of them running simultaneously here.
Vehicle 3. Go! This is Vehicle 3. Go! Just got hit. We're down. We're down.
So there's stories, there's narratives that go along with this. And that kid dying, all the cinematic stuff, you know, a guy on your squad was kicking a soccer ball with him earlier on, and he pops up like a little friend of your squad. But it ends up that he runs ahead of your squad after a soccer ball and hits the tripwire that was meant for your squad and dies, and the mother's there screaming. Horrible stuff. Well, stations in an emotional obstacle course, but they provide a context where we can deliver this kind of treatment in an experiential fashion. And we deliver it in the Oscar program from the Marines and the Navy. We deliver it with a virtual human mentor that'll walk out. And I'll show you real quick.
Let's start with learning how your body reacts to stress.
So he sometimes appears out of nowhere in the vehicle, or he'll walk through the smoke and rubble and look at the kid and say, okay, let's talk about this. And deliver, in this case, after the IED, you're out of the vehicle, he takes you into a nearby building and goes through some very low-level stress management, as you'll see.
The caveman part of your brain, the amygdala, goes into action. Its job is to identify threats. If the crap you're in is real, the caveman starts beating his drums, sending signals throughout your body, telling it to get ready. I worked with a sergeant who stayed amped after serious encounters, sometimes for days. Not good. When you get a chance to lower your guard, you want to make sure you help your body recover from the stress response that was initiated. One way of doing this is through a simple breathing exercise. It can help calm your heart, normalize your breathing, decrease blood pressure, and help you sleep. Let's try it a couple more times. Breathe in silently through your nose, deep into your belly. Now slowly exhale from your mouth. Let me hear it.
So the episodes go 7 to 10 minutes, and then the mentor sessions another 5 to 7 minutes after, depending on the content that's delivered. And I visualized 30 episodes. We had enough money for 6. I just want to show part of what we did in the last 2. We killed off the inspirational leader, kind of like in Game of Thrones in the first season. You know, where you guys, Game of Thrones watchers, you know what happened. I don't want to ruin it for anybody else who hasn't seen it. But somebody dies and it's like, how could they do that? Anyway, we did it a little early because we only had money for 6 episodes. We wouldn't kill off the inspirational leader until episode 15. So you really get to know him and feel bad when he dies. But the whole goal is to address death and grieving. I'm going to skip through the death scene. This is all happening here. And go to, this is where it happens, the mentor walks out, the inspirational leader said, to go right to the next episode in the forward operating base, where it mentors with you the whole time as it goes to Christmas past, seeing how each member of the squad is dealing differently with the death of the beloved leader, so to speak. And these guys will all have their say here, and everybody get to say what they feel, just mimicking what happens at the base. And the mentor will...
There's a lot to be learned from the experience of others. Let's start with Johnson and Bell. and see how they're dealing with the tragic death of Soto.
Each vignette illustrates different type stages in the grieving process.
What's going on with you, Belle? Nothing? You hurting?
I feel fine.
Then what's with the silent treatment?
Look, you live, you die. Soto's time is up.
You're a cold son of a bitch.
Just keeping it real, man. Otherwise, you can make yourself crazy with this business.
You dick!
So you got the denial, you got the anger, two guys having a heart-to-heart late at night.
What? I don't know. Just talking about this stuff helps. I mean, it's good. It's all good. Do you think we could anytime, Corporal. Anytime.
The single most important factor in healing from loss is having the support of other people. Even if you aren't normally comfortable talking about your feelings, it's important to do so when you're grieving. Sharing your loss makes the burden of sorrow easier to carry. It's not a sign of weakness, it's a sign of strength.
So you get the idea, you know, you could spread out over, I see 30 episodes across a deployment cycle, all the different things that can happen, and have a drama where you want to find out what happens in the next episode as you go through it, so you're engaging people in the content. That's our 6 episodes. We're testing them out in a number of ways. We're also drawing bloods before people go to look for biomarkers, physiological monitoring, psychophys monitoring, see how they react in the environments, to see if we can get a window into the soul. We've got a study ongoing now. We got a unit before, a special ops unit that went to Afghanistan, and they're coming back in 2 weeks. We ran them through this, and we're going to get them when they come back, and we're part of another study as well. But basic questions we want to ask. A small unit, 30 folks, so we're not going to get sledgehammer results, but we'll see what we get from it, and we'll hear more about that in a minute. So now, clinical training, and I know I was only supposed to talk for an hour.
We're fine.
You okay?
Yeah,
I'll go. I can finish it up 15, 20.
Yeah, no problem.
Okay, so virtual human agents. These are not just the avatars that you would see on Second Life that somebody could drive. These are software-driven agents that are programmed to react, whether you type in text or you click on a menu of response options, which I think is pretty lame, or you have natural language, voice recognition. That's really the way this stuff's got to go. But that's the input. So we've developed a bunch of these over the years at ICT for a variety of purposes. That's one of the core missions at ICT, is to advance the virtual human work. And around 2007, we modeled my wife's therapy office. She's a psychologist in Pasadena, and we actually built a resistant teenager as the first prototype, but I want to show the video of our second patient, and a doc actually interviewing her. The guy you'll see was just given a card. This is at Keck. I was given a card saying, mother called in, daughter won't go to school anymore, stays up in her room. That's all he knows.
Hello, my name is Dr. Davis.
Hello.
What brings you into the office today?
Something bad happened that night.
I'm sorry to hear that. Can you tell me what happened?
I was in the car with Eddie, and he stopped the car and wanted me to kiss him, but when I tried to stop him, he threatened me with a knife.
When did this happen to you, Justina?
All right, now the language is going to fail here.
I was so scared. I thought I might die.
She's not answering that direct question, but the system didn't recognize the question, so it goes to a default, which maybe a patient would say anyway.
Yeah, it still is.
So they showed some empathy there, and because she went off a little bit.
Find yourself still being bothered by what happened?
Whenever thoughts of the event pop into my head, I put my iPod on real loud.
Is a real patient talking through an avatar?
You
or
mentioned
is-
thoughts pop into your head.
It's all automatic.
What kind of thoughts pop into your head?
I want to get away.
When you think about it, you feel like you need to get away.
Nice reflection. But
That horrible time replays in my mind
this is the last
over
one.
and over.
So you would never mistake that character for the real thing. But once you start getting responses that are credible, you saw this guy start to get more engaged. He was doing some proper clinical reflection and empathy statements and so on, trying to get more. So that was our really our first one, and we still hadn't gotten any funding at the time. So this was taken from another project, taking some of the stuff. I think we had maybe 240 questions that were programmed in and about 400 different types of responses that were linked up in a web. But over years, this was the first resistant teenager. We started building these things out a little bit, worked with social work, building out their system, and now, oh, you saw him already.
Good afternoon, Sergeant.
Here's one for motivational interviewing. And this is, well, let's let it play a little bit, and then I'll just talk about what this one does. And this was with social work.
Stands for the Motivational Interviewing Learning Environment and Simulation.
Look, I'm sure you've heard it all before, but, I mean, here's the deal. What do I have to complain about anyway?
Miles brings together military experts and the experts of the School of Social Work and the Institute for Creative Technologies in order to build a system that teaches clinicians how to effectively use motivational interviewing in interactions with returning veterans and service members.
Motivational interviewing is a specific...
So you notice there's choices here.
Evidence-based that we use to work with
So-
clients who are feeling ambivalent. When we talk about the Miles platform, there's actually two different...
What happens there, let me back this off. What happens there is we had built out a full natural language system, but it was very complex to author and to change the character. It was one of the first ones we built and weren't so good at authoring. So they wanted something that would specifically train motivational interviewing, and we built it off a system that had been built for leadership training, where to make sure that there was no flaws in the voice recognition, you had 3 choices that you could pick from. And the branching would take place from whatever choice that you picked. And you would say it. You wouldn't just click on it. You would basically read it. I don't particularly care for that approach, because when people read rather than self-generate, I found when I was doing it, I was, all right, I'm going to go with number 2. And I would read it. And then when the answer came back, was, what did I just say? Because it wasn't coming from me. It was from a choice thing. But maybe it's okay for scaffolding. And the beauty of that system is that you have a room where the person interacting is in, but the whole class can observe and have clickers and can pick which choice they would pick. And the teacher can get an assessment as to the basis, the knowledge that the whole class has. So it's a good classroom tool. It may be a good ramping up, but I don't really like the choice thing. So anyway, so that now we're evolving everything now into a toolkit for authoring, because we learned our lessons that we need to have better authoring to be able to modify and build more cases much more efficiently. And so we got funded to build a toolkit that will allow medical educators, clinical educators to go online and author cases, author their best cases, and then have them available online. And so just some scenes from different elements as we're moving along with this thing. But here's what some of these patients look like. Different background settings that can be selected, different character types, different ethnic backgrounds. So you can see these things are coming along. Online, we have a point-and-click version of a virtual Ebola case. I can send you guys the link. You can just play with it. Just pick which one you would say. But our team is making it so that there's a text interface, but if you have an already trained voice recognizer like Dragon, you can put a plug in and populate your texting, so you're actually talking to the character. Yeah.
Is it in different languages? Or just all
Not
in
yet.
English?
Not yet. It's all in English right now, but that's the next generation of moving forward. Not that hard, really. I mean, some languages it will be hard, but the common languages, I think we can do. Okay, now final section. Sim Coach. This was the guy you met earlier. He was built, funded by the Defense Center of Excellence, to be an online resource that people could go to if they didn't know if they had a problem, service members, veterans, and their family. They wanted to privately get information about PTSD, substance abuse, TBI, and so on. And, you know, the whole rationale was to break down barriers to care. You know, we knew we have stigma, we know we have access problems. Sometimes people don't even know if they can get any benefit from treatment. So this was designed as an approach to address that, designed to attract and engage people that might not otherwise seek help, motivate them maybe to take their first step, help them understand their situation, and inch them a little closer, but not to provide really powerful diagnostics or therapy, not to replace people, but to fill in a gap where there isn't going to be a person or where that person wouldn't seek a real person. So let me let him play.
Hi there. The name's William Ford, but you can call me Bill. Welcome to Sim Coach.
Hi, Bill. So what's Sim Coach?
Sim Coach is a safe place for war fighters and their families to talk about the things that are on their minds.
So, who are you?
I'm a virtual human, which means that I'm based on the real experiences and personalities of actual war fighters and their families. Anyway, I'm here to listen, and I'm here to help. Anything you want to talk about?
Talk to you? How do I do that?
Well, you're doing it right now. Just type in regular English. Anything troubling you?
If there is, why would I want to talk to you about it?
Well, here, I'll tell you what. I made a video that tells you a little bit more. I'm going to pop it up over here on the right. Not all the wounds of war are physical. When you don't dress a wound, it gets worse, doesn't it? Sim Coach is here to talk about the issues weighing on your mind without worrying about anyone finding out about it. You start off by choosing a Sim Coach that's right for you.
Oh, hi. Hope you weren't waiting long. Welcome to Sim Coach. I'm Ellie.
Then just type in English. Ellie can listen, understand, and respond.
If you don't mind, I'd like to ask a few questions so I can figure out how to help you better. Is that okay? Everything you say here is completely anonymous, and we've taken a lot of steps to keep it that way. If you don't mind my asking, how's your sleeping been lately? Here's a link on the do's and don'ts of good sleep hygiene.
Ellie can send you links to resources, show you a video, administer questionnaires, give you advice, or just tell you a story.
So my younger brother Alex was in the Marines and deployed twice. I don't want to say I know what he went through, because I don't. But something he said kind of reminded me of something you might be going through.
But the most important thing she'll do is listen to yours.
That must have been really rough. Go ahead and tell me more about that, if you can.
Sim Coach was developed by a whole group of docs, computer geeks, experts, and writers to be as helpful as possible. And the more the people use it, the better it's getting, all the time. Sim Coach, a safe place to talk to someone at a time when it's needed most. Just head over to www.simcoach.
So that's live. You can go up there right now and interact and see a little bit about what's done. Now the neat thing, the military sometimes is like venture capitalists that don't expect to get paid back. And it's great because they invested in an architecture and a toolkit. We had to build a toolkit to make it so we could update and adjust the characters as more and more people interacted with it. We saw where it would fail, and we'd have to go in and build out dialogue branches and so on. And we've gone through a whole variety of other things. So this is what the roundtable toolkit looks like. You can go on, these are just different scenes from it. You can go on to the site and actually begin authoring dialogue, selecting a character, and typing in the question. Like, say you wanted a question about HIV. What are the stats? Person comes on a site. How often do people my age get HIV or whatever? And the character goes, well, how old are you? Well, you type that in, and then punch it in age, and then you program in whatever the stats are, and you go back and forth, and you got to anticipate all the dialogue, put it in front of people, and then continue to evolve it that way. But once you have an utterance that you want the sim coach to produce, then you hit send, and it goes to a render farm, and it animates a character that asks that kind of a question with gesture and facial expression. As you're typing other stuff in, then it'll pop up in your queue, and you can look at it, and that looks okay. Oh no, I don't like that. Why is he smiling for that one? Let's change that. And you can go in and you can edit, and it'll go back and re-edit, re-deliver it. So that's how that thing works, but that's available now. We did Braveheart, not that Braveheart, but this one, Atlanta Braves site, where as part of Welcome Back Veterans program for Major League Baseball, they wanted a little sim coach for the Atlanta area. So we edited it and made a small one that would help people in the Atlanta area find out where resources were. Let's see, ProCall, this is professional quality of life. This is actually shelfware now. The Army spent a bunch of money to have a character administer this once a year to every care provider in the military as a way to monitor their health, compassion fatigue, and secondary PTSD. But they could answer honestly, and she would give interpretations based on the scores from the 30-item test and begin to help a person develop a self-care plan. But the guy who funded it, the colonel that funded it, ended up getting promoted into another area, and the person that replaced him just didn't really, it's sitting on a shelf right now, basically. But it did teach us how to build these self-care things that can get added into the sim coach.
Do you see that going to like therapists in the real world?
Yes.
Kind of like immediately?
Yep. Well, a little bit of modification. It was just because it was built around a military context, but I think we used a civilian character, and I think we could retool the dialogue and what you do is when you're making these utterances, it comes back with a computer generated voice as a placeholder. The computer generated voice is getting a little bit better, but once you hone your dialogue system, then you can go in and you can record your own voice to replace the computer generated voice, or you can bring in a voice actor like Bill Ford. That's a guy up in Canada that we send him lines and he records them in his studio and sends them back as we build new Bill Ford lines. And Ellie is a woman that works at ICT, actually. Did this one for the library at USC.
Hello, I'm the virtual librarian. I can help you search Medline Plus, a service of the National Institutes for Health and National Library of Medicine.
Yeah.
I am from the Institute
Anyway,
for...
that's him. That's like the new version of the movie The Time Machine. There's a virtual librarian. It's a holographic character. When the guy from the 1800s, goes into the future in the 25th century. Anyway, but the coolest thing about all this is now we can take this stuff and start translating it for other purposes. Librarian is one, but here's one we did for the Dan Marino Foundation, where we build job interviewers for training high-functioning folks on the autistic spectrum that are high teens, young adults, and they can pick out of 6 characters. Each of these characters can be set at 3 different behavioral dispositions, so they can be the soft touch interviewer, the neutral one, or the hostile interviewer. And different backdrops, as you've seen, like Hollywood sets that get popped in. And it runs on the same sort of an architecture, the same authoring capability. And now those combinations, you can have 180 different types of training trials. Here's this little It's called VITA, the Vocational Interview Training Agents. And you go in, you pick which character, you can pick her personality, and you can set the background, and then it runs. So we're trying to make it more
Hi, thank you for coming in.
human.
It's nice to meet you.
She's a soft touch interview on this one. We submitted a pre-proposal for this and got nuked. I can't believe it. It was for a DoD project for working with relieving caregiver burden. But our idea was simply to have a virtual buddy that would pop up on your phone, pop up on your screen, pop up on your smart TV, have the house network, and that character could be authored by family members of people with mild dementia. So you could author biographical knowledge into the character, and you could scan in photographs across a person's lifespan. And the character could serve as a prompting, reminder, medication thing, but it could also answer questions about the person's life. I forgot my grandkid's name, or the character could say, all right, so let's start today with a couple questions about your past. Pop up an image and go through a reminiscence therapy kind of a thing. Tell me when this picture was taken, who was in this picture. But the family member could author all of it. And the family member could send messages through the virtual buddy. Anyway, I'm still ticked off about that. I just found out yesterday that we didn't get invited for a full proposal for that. Finally, now we're going to go into the realm of science fiction. This is a DARPA project, and basically, think of a sim coach and add a webcam, a Microsoft Kinect, and a microphone to give the character eyes and ears on the user. And that way, the sim coach can now see your facial expression, your gesture, your posture, and your vocal prosody. Not what you say, but how you say it. Okay, we have software that can do that. And we call it Sim Sensei. And it's basically a kiosk type format that you can go through interviews with. It can ask you questions. Think about it as the entry point at a crowded VA, maybe, or I'll give you the rationale for it.
Hi, I'm Ellie. Thanks for coming in today.
Let me back that up real quick. This is you're gonna see what's under the hood now. And this is like a webcam can track these movement points on the face without any markers. The Kinect is capturing body movement and looking down. Actually, the webcam gets to looking down, so we can get fidgeting and all these other things, and vocal parameters. Let's see, this will start.
Hi, I'm Ellie. Thanks for coming in today. I was created to talk to people in a safe and secure environment. I'm not a therapist, but I'm here to learn about people and would love to learn about you. I'll ask a few questions to get us started. And please feel free to tell me anything. Your answers are totally confidential. Are you okay with this?
Yes.
So, how are you doing today?
I'm doing well.
That's good. Where are you from originally?
I'm from Los Angeles.
Oh, I'm from LA myself.
She lives in a
When
computer
was the
there.
last time you felt really happy?
When was the last time? I don't know. Yeah, I'm not someone who's really like, I don't have any real highs. I feel like I'm a level person. It's just happy. I guess to answer your question, probably a couple months ago.
I noticed you were hesitant on that one. Would you say you were generally a happy person?
I'm generally happy. It's just lately there are things just keeping me down.
So what ends up happening here, or she's going to say, can you tell me more? What's happening is we're tracking all these things, and it can serve two purposes. It can feed back into the logic of the agent, so that the agent asks a follow-up question, and we try to ask more open-ended type questions, because we're not really looking at what they're saying so much, but how they're saying it. And the character goes, that question was hard for you. Can you tell me more? So it can feedback and cause different types of follow-on questions to occur. It can also drive her rapport building. So if somebody is like going like this, character can kind of nod back. It can pick up that kind of a nodding and gesture kind of thing. And but we can also quantify over time, over the course of a 20-minute interview. And our research now is looking at, with known groups, looking at ways we can detect and computationally analyze psychological signals, behavioral signals. So over a period of time, we've had about 555 people go through different conditions, face-to-face with a real person where we're videotaping and annotating everything. That was at the basis of it. Running these characters, Wizard of Oz style, where people would come in and before we had the actual software built, two wizards would control the character. One would control the vocalization, the other one would control gesture. And then finally, the automatic system, the AI system, which we're at with 181 people in the military and 61 in the non-military. And when you just look at the stress, if you look at people that score high on a PTSD scale or a depression scale, look at it together, you see a lot of overlap. We looked at people from US vets, which are veterans that are really down and out, that are homeless, that are really a lot of substance abuse. You see things like over the course of a 20-minute interview, the system automatically differentiates the groups. The stressed people, less joy, more sadness in facial expression, more vertical eye gaze. With the smile intensity, you see overall much less smile, robust smiles. But when you look at depression alone, depressed people who score high on the depression scale, will smile as many times as a healthy control, but the smiles will be very short and not very robust. So it's almost like polite smiles. We can pick that up on the face. Hand self-adapters, hand fidgeting. We had a finding with the PTSD only group that touched their face a lot. Leg fidgeting, vocal parameters, which I'm not fully conversant on, as your buddy Stefan and Peter have been looking at this stuff. But they're telling me that the voice is the window into the soul, that the pitch, the variability or lack of variability in pitch. So the things that us as clinicians, when you do an interview, you can tell if somebody has flat affect by sometimes how they speak and so on. But space between words, latency to reply, things like that.
So can we just go back there for 1 second? Do you have parameters that can allow you to say healthy, not healthy?
That is,
automatically?
that's
or
what we're
currently establishing them?
We're establishing them, but this is where we're heading with this, because in our last pass through the data, we've got pretty clear metrics on these various markers, these indicators, and I think it's a big data issue. You know, we just got to run lots and lots of people in known groups. You know, the biggest challenge was that most of the people that scored high on the PTSD scale also scored high on the depression scale. So, you know, parceling all that out is going to take a lot. And, you know, we're not the only ones doing this. This was funded by DARPA. They have their ulterior motives, I'm sure. They want to be able to sense the state of a person going through a checkpoint, I'm sure. But they did it in the context of wanting to detect suicide risk in people. You know, what are they going to do? They're going to track people's faces when they're not. I mean, it's kind of a stretch, but that was the reason to be for this project. And they had like 4 or 5 different performers on the project. One guy looked at case notes written by MDs and did a linguistic analysis and was able to predict suicide based on the case notes. Then he got access to Facebook pages of people that had committed suicide and did the same analysis and found pretty good predictors, patterns of types of responding that predicted the person would actually follow through with suicide. And Facebook now is contracting with them. And I think the concept basically is, you know, if all of a sudden you're starting to exhibit the morbid pattern in your interaction, maybe on the side in the little bar, the ad bar that pops up, you're going to get help is out there. Here's a call-in number, you know, Jesus is Lord, or whatever, you know, whatever the message is, they're gonna put up there. Just like they put up dating sites and cooking sites, and they already do that. So it's a big data sensing privacy thing. So, you know, we worked with a guy at MIT, Sandy, I'm blanking on his name, but he does this thing called reality mining, where they take the data from your cell phone, how much you use it, where you are, GPS, and infer, you know, aspects of yourself. That he was one of the performers on this. So, you know, I don't know if this stuff will have a bad ending in terms of invasion of our privacy, but I can see places where it could be useful, and I'll show you one in a second here. I mean, one of the ideas is you could do it with the virtual human, but you could also be using the indicators with somebody in actual therapy sessions and developing a profile of the person. I mean, a good clinician should spot these things, but maybe someone who's still young in their career might not spot them, or maybe it's too much, or maybe there's a way to quantify things. At the end of the session, you get a little report that compares it with the last week and the week before, and you can see that out there, or you can compare it with a reference standard with the known groups. You know, this person showed the behaviors very similar to people that have committed suicide. You know, MMPI, Dust Bowl empiricism, if you like. Let's see. So now here's where we're running a test right now. First off, we did a study where we had 77 folks go through this. One is told that you're talking to software. The other one is told there's a Wizard of Oz behind there that's driving the character. All right? And you find that if people think they're talking to software, no human in the loop, you see different reactions, less ratings of fears of being evaluated, lower worries about impression management, more intensity of sadness displayed. Like all of a sudden now, it's like people are feeling more safe talking to a virtual character about things that are going on with themselves than talking to a real person. So is there a place for that kind of stuff? Well, we figure this kind of a finding in conjunction with this kind of sensing thing, whether there's a feedback loop that gives the user information, or we use it in cases where anonymity may matter. There's a study that was done where they give people, when they come back from a deployment, the post-deployment health assessment with like 7 questions about mental health. And most people, when they come back, no, I don't have that. No, I don't have that. I'm fine. Let me get out of here. But then you yank them out of line and give it paper form, because they do it on a computer and it's in their permanent record. Privately, they go in a room and they're told, fill it out honestly, throw it in a box with a million others, don't sign it. You see 2 to 4 more times of reporting depression, PTSD, suicide ideation, interest in receiving care, when they could do it anonymously. So what we're doing in our Colorado study is we did the Strive part, but we also had a 20-minute SimSensei interview. And can we, in that private session, get a better assessment before they're deployed as to their health? And when they come home, can we get a better assessment when they're talking privately to the character? And does it predict long-term effects? So this is what we're doing with these groups. We've already got them, did Strive, we did SimSensei, now they're coming home, we'll just do SimSensei and then follow them for 6 months and then a year later. And this is also now going to become part of our military sexual trauma assessment. So basically, in that assessment, at pre, mid, and post-treatment for the VR exposure therapy session trial. We'll have the standard self-report, structured interview, the CAPS testing, and a psychophysiological startle response. So 2 of the 3 domains you can get from a human, what they tell you and what their body tells you, or what their innards tell you. And now we'll have SimSensei at each of those points as well, what their behavior, the 3rd leg of the measurement stool, what the behavior tells you. And then take a look. You know, with the population, we expect to get better over time. We're hoping. So I want to conclude by saying this. War sucks, but it does drive advances in medicine. And for better or worse, you know, you see the wound-to-kill ratios get better. More people, 3 people wounded in Vietnam, 1 dies. Now it's 9-to-1. Battlefield medicine's gotten better, but it also means a lot of people are coming back with horrific injuries that would have died in previous wars. But it also drives advances in these areas, psych, neuropsych, rehab, and so on. World War I, Army Alpha Beta kicks off an IQ testing movement, and later neuropsych. VA internship program gave birth to clinical psychology. Psychology was an assessment and research profession before World War II. People came back with combat neurosis and battle fatigue, and it overwhelmed psychiatry. Psychology or VA set up an internship program. That was really the real birth of clinical psychology, as well as Luria's work with TBI. I don't know if you guys knew this, and IMH was formed by an executive order. So people complain about executive orders in the next couple of weeks. Think about this one. I mean, that's how NIH was formed to address combat neurosis. Arab-Israeli wars, more neuropsych rehab, Vietnam. So my case is OIF, OEF will drive advances in technology. And I haven't even talked about the TBI work that's been done, and the physical therapy work, and the cognitive rehab work that's been done. But in all these areas, smart prosthetics, rehab, PTS, I think that, as you can see, it's been a driver for the technology and a driver for research that I think will spill over and make a difference in civilian work. And certainly with PTS, you know, there's certainly a fair share of people that could benefit from better care and better options. So, as usual, I'll leave if you got a key drive, it's a 3 gig talk with embedded videos. I'll leave it here, or I can put on FTP site for you to download. You can have anything there. That's me. And we come to the end. Questions? Ah.
Thank you.
Or no questions, it's all right. Yep.
So that was really great. Thanks for your talk. And just a quick looking forward, like I wanted to hear your thoughts about, you know, this in terms of accessibility. Now we have all these smartphones and tablets and phablets. So some of these components, how translatable are they going to be with, you know, a guy with a smartphone? And then a second question is, you know, these voice stuff like Siri and Google and all this stuff. Like, what are your thoughts on possibly incorporating this into technology like that?
Definitely mobile. You know, I don't think everything is going to get put on your phone, but that's a way to be in contact with patients or clients, or whatever, or to have a handy, powerful tool for accessing things. Think about relapse prevention and addiction. You know, I remember I used to run smoking clinics in grad school, and we'd type out an index card, or a secretary would, the 3 reasons for why you're quitting and the 3 benefits that you get from quitting smoking. Put it in your wallet, and when you're in that bar and having that urge state, pull this out, read them, say them out loud, and the urge should pass by the time you get through. Well, maybe you have a virtual human that is supportive, or maybe you animate a familiar character, like a family member. You know, when it comes to, we're doing work with Kinect, using the Kinect to scan people in 3D, go around and wave around, and you formulate a 3D representation of a person. Maybe that can be put into the cell phone. I think there's no doubt that having, There's going to be a lot of noise to signal, though. There's going to be a lot, like there already is with phone apps. There's a billion fight your depression, cure your anxiety apps, that are, self-help books, but, thrown on a phone. So there's going to be a lot of those. But I think there's no doubt that mobile is going to be important part of this. And directly, I think, more than self-help, well, I guess this fits in the self-help. I think between session homework and support, and maybe you're wearing a watch that's recording your heart rate, and just like now you have the things you can wear. You get a phone call. You come into the clinic now. You're having the beginning of what could be a heart attack. Well, maybe we can do things like that in psychology and monitor where a person is if a person consents. So there's no doubt, and we are working towards that. I consult for a company that has a nurse agent, but it's not an agent, it's just a representation of a person. And the doc can go in and type questions that can go out, or have standard questions that can go out to a person, and then have them rate their mood, or did they take their meds today? Yes, I did. No, I didn't. I took it at 1, 2, 3. And they can use Siri to reply back in some cases. So all that's happening. The voice recognition fits right in with that. We used to pay so much money to a researcher on our main campus that allegedly had a good voice recognition system. And it was an endless pit of money. And it never worked right. Now you got Google, Microsoft, Apple, and who else competing to win that space. That's what you want. We're not going to throw any money at anything. We're going to license because it's going to get better. We're going to be talking to our computers as much as we're typing to them. And we should be by now anyway.
So you don't write your own algorithms?
Well, for most of the stuff, yes, but for voice recognition, no.
That's taken from where you
were. That one that you saw with the suicide case with Google. There's another one that's a decent research one developed by a company called BBN that we've been using, but we'd rather put our money into the. It's not voice recognition is just the input. Then what do you do once you convert that voice to text? Where does it fit in a web of logic? That's the dialogue management. That's all ours.
So how far, in terms of the voice recognition, is it pattern recognition? So understanding how people talk, is it at the level of patterns, or are you able to actually understand the meaning of what people are saying?
Well, it's hard because people can say something and it's the same words but with a different emphasis. It means something different.
But just plain text?
Yeah, I mean, what all voice recognition does is convert to text, and then there's a text analyzer that goes through it. A lot of it is really easy. A lot of it is real simple. But when you start to get more nuanced in your language, but if you can, if you can shrink down the domain. So, for example, nobody is going to ask a virtual patient, when do you think we're going to put a man on Mars, or a woman on Jupiter, or whatever, or Venus. You say you don't have to worry so much about those questions. Eventually, I think there will be a giant language dialogue system that'll run in the cloud. And we'll be talking to our computers so much, they'll learn the idiosyncratic inflections of our voice, and that'll become a profile as I talk to my computer more and more. That'll just grow and get better. And as my voice changes with age, it'll change the record. I mean, that's what we're looking at. And we're talking about input devices. It's the logic of what it means. Like when I say, I'm feeling horrible, well, all right, now it's on you. What are you going to have this character, or what are you going to have this computer say back to you that's going to be meaningful or hopeful?
So is it looking for patterns or words like horrible and then having a pre-programmed response, or it's actually you can understand I'm feeling horrible as a sentence and then what that means?
I think they call it bag of words. It's like that key word, like horrible.
Okay.
and then it goes back and it looks at whether it was a question or an exclamation. There's all these different approaches to dialogue management and understanding. And that, again, is kind of out of my league, too. I have good friends that do that hard work.
So are you finding that there's, I think you could call it something like a contextual uncanny valley, so that if someone enters this virtualized space and it's dissimilar from their own experience, that they can learn from that or make change based on that similarity. And then on the other side, if it's very close to their experience, let's say war or let's say MSM in LA, party scenes, and you want to make some behavior change, if it's, is there a gap in there? Is there that valley that you find where people can't, it's not close enough, or it's not close enough and it's that space that is ambiguous enough that it affects clinical outcomes?
I don't know if the people, anyone's done any research clearly enough on that, because it's a hard question. The uncanny valley came about from the robotics field, where up to a point, the realism of the robot, it was fun and engaging to talk to them, but then when they started to look more human-like, it was kind of creepy because they didn't have all the...
And apparently elicited violent response.
Yeah, it's like, ugh. And people said this, it was going to be the same way with virtual humans, and people bring this up all the time, but there's no data on that. Now, I think there's there may be, for any condition or any clinical population, there may be an optimal set point. I don't know what that is. I do know that that with the virtual Vietnam scenario that Barbara Rothbaum had built in the late 90s, it was very primitive. But it didn't, with that population, it wasn't hard. It was an easy room to work. They related to this rice paddy and the sounds, and when they came out, they actually claimed that they remember things in the simulation that weren't in there. The water buffalo and a rice paddy, they didn't have one. Gunfire from the side, none of that. I think this is where psychology and where research is going to start focusing on. Once, the reason it hasn't been done now is it hasn't been easy to author these things and to make it so it's almost this real, and then build the same environment but make it way more real. So, you know, when you've got to fight with NIH to get money to run a proper clinical trial, and then you got to add on to it development costs for simulations, you're not going to get it. But now as the authoring gets a little bit easier, I think those are important questions to ask.
My question is, you mentioned that with the exception of sort of the smell generating machine, most of the equipment was actually not terribly expensive. But if someone wanted to incorporate some sort of VR application to a substance use intervention or risk reduction intervention, how expensive is sort of the whole authoring process to develop it?
If you had an interest in that, we did a talk. I did talk for LA County, and a fellow from University of Houston, Patrick Bordnick, came. He's a PhD social work guy that has developed Q exposure environments and gotten NIDA money to do this and to run trials. And virtual bars, virtual social scenes, just high-risk situations, and the idea, with smoking or alcohol, and he has a cocaine world. I think they have a shoot house as well, and basically put people in that environment, raise their urge state, but they can't use. They're in your office or they're in rehab or whatever. Teach them refusal skills, coping skills, whatever. And so he's doing that work. He has a variety of these scenarios, and he's a good guy. He would probably share those environments. They'll run on that. I run virtual environments off of that laptop. I just plug in a headset and a tracking device and can run it off of a $2,000. It's a good laptop. So you can do it. It's going to get better. There's a headset that's coming out called the Oculus Rift. This is the company that Facebook bought for $2 billion. It's mind-blowing, but it's like putting on a ski mask. If you even need it, you can deliver these environments, turn off the lights and deliver them up here and have a user interface like a game world. But if you want that immersion, if you like, I think some things you want to have a controlled stimulus environment. I think for the addiction stuff, you want that. There was a UCLA study, Colburn, or somebody built a thing on Second Life and built a little kiosk, and it was a Q exposure room. Culpepper, I'm just getting so bad with names. But I can look it up. I have it somewhere on my laptop if you're interested. There was somebody here at UCLA that did this. So $300 headset, though, that's be coming out soon. And you can see Samsung has put out the Gear, which uses a cell phone. It puts in a little device. All these things are getting a lot cheaper. But the Oculus will be $300 with tracking, wide field of view, high resolution, plug it in. So the cost isn't going to be that expensive. The authoring is. If you wanted to build a new virtual world and specifically design it the way you wanted, that's probably going to be the most costly part of it.
Paying for people's time and expertise.
Yeah, paying because you got to pay for art, and it's 3D art and some stuff you can buy online now. There's software we use called Unity, and there's a store called the Unity Store, and we're going to start putting some of our stuff that we've built online and sell it and try to generate money for the lab that way. But you can buy anything. You can go in and say, well, I want to buy a grocery store, or I want to buy a liquor store, and people have put them online, or I want to buy liquor, I want to buy specific liquor bottles. To put,
One of the best single malts.
So when you come to my house, that's what you're going to get.
Yeah, virtual booze, that'll never catch on.
All virtual.
No way.
I have a question for you, which is, we've been talking about all vulnerable populations, and you talked about how the confidentiality can be secured, but how do you create security in the mind of the individual who's vulnerable? This is essentially creating a whole transcript of the entire encounter, and now embedded to who knows where, and sent to who knows where, particularly in the military. You might be very concerned about that. Certain populations we're talking about, people could feel very vulnerable about what they're saying into this device, whereas if you're meeting with someone, you have some confidence that they're not going to be able to replicate entirely the whole exchange. So,
It's just, it's a matter of trust. We have a whole set of dialogue loops around in the SimCoach one that says you are not being tracked. This is a part of the rationale for this project, a safe place to talk to someone at a time when it's needed most, that kind of crap. Look, if you're going through the internet, you never know who's going to plug in, and you have security. There's a certain level of security that's built into this, but as we know now, everybody can, the government seems to be able to do it, So I don't know if we'll ever get over that, short of, the opposite of cloud computing, where you disconnect from your network and you've got a software package on there and everything lives in that. But, there's always going to be that doubt. But people in the end, pretty trusting.
I don't know what the military has to do to comply with, if at all, with HIPAA restrictions, but certainly a lot of the cases here would have HIPAA restrictions. Do you even deal with that?
No. I don't know if this would be considered HIPAA compliant. I don't know all the steps you would have to go through to document that the line is secure. I think there are some assurances with the Google cloud. No, we're using an Amazon server actually, and they claim a lot. So I don't know what you would have to go through, but it's the same thing with doing teletherapy,
right.
And that is something that can bring a lot. It's the cost benefit. Can you broaden access, but also introduce risk? I don't have a good answer. I don't know if anyone would on that.
How about rating automatic emotional tone? So I know two people who are working on it, but it seems very preliminary. I wondered if you knew anybody else. They like language readers, they have automatic ratings of positive and negative tone. Do you know?
So in your voice, like when if you
Yeah,
were
in your voice.
talk.
Do
Ah.
you know,
That-
I saw a presentation from Northwestern and one from MIT Media Lab. Both were very preliminary.
It's this is Cogito out of MIT, and this is the fellow whose name I can't remember, who was a big MIT computer scientist, but he was a guy that we partnered with on our voice analysis, and it's a Cogito voice analytics, which we're now in the process of replacing because we don't want to have to be paying ridiculous license fees over time. They're pretty good. It works pretty good in differentiating groups, interacting with SimSensei. I don't know what they're offering. They're offering stuff that works on a phone.
Right.
So you can talk on your phone, your patient can talk on their phone. I trust them. I think there's good science there, but I don't think I'd be able to say, you know, what's good and bad since we worked with them. We worked with them about a year and a half ago, and we're in the process of replacing some of their software. I think the voice does tell a lot. I think we, as trained clinicians, we can tell. If you know somebody, your wife, your loved one, you know, you can tell in a millisecond when there's something wrong, just with a little bit of a tone. And I don't think it's such a stretch to think we can define those things and run them through a better ear than I have, a better computer ear than I have, and be able to analyze it. I think it's a direction worth going into.
Other questions?
If
Thank you.
Yeah,
This
thank you
has
so
been
much for
really
coming.
good.
Pleasure. You guys have an open invite to come down anytime and visit the lab if you want to organize a trip down there. We have regular tours, but if you wanted to come at a certain time, we could